Hello, and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today we have the pleasure of speaking with Dr. Matthew Weir, a renowned nephrologist and long-term CMHC faculty member. Dr. Weir is a professor of medicine and division head of nephrology at the University of Maryland School of Medicine. He's also an expert in chronic kidney disease, which will be our topic of discussion today. Thank you for joining us today, Dr. Weir. When it comes to screening and diagnosis of CKD, what are some of the current gaps? And what are some clinical pearls that clinicians and especially non-nephrologists should keep in mind to better screen at-risk patients?
The diagnosis of chronic kidney disease is pretty straightforward. But I think the most important thing is to make sure that there is an evaluation of both blood and urine tests. And the blood test should use the serum creatinine, from which one can calculate an estimated GFR. And the urine test is done to identify whether there is any albumin or protein in the urine, or also the presence or absence of white blood cells, red blood cells. So screening is pretty straightforward, but you do need blood and urine tests. And this is particularly important on an annual basis in all adults, especially if they have hypertension and or diabetes.
Okay, thank you. That's very interesting and good for everyone to know. How has the screening and diagnosis of CKD changed in the recent years?
In the recent years, the screening for chronic kidney disease has changed largely by encouraging healthcare providers to measure either urine albumin or urine protein, and not just with a dipstick, which, as we know, is concentration dependent, but specifically with a spot urine protein to creatinine ratio or a spot urine albumin to creatinine ratio. These are the most important opportunities we have. And it's now currently part of most major guidelines in terms of screening for chronic kidney disease, whether a patient has diabetes or not.
Okay, thank you for sharing that info. When it comes to treating CKD in order to prevent progression in cardiovascular issues, there seems to be a lot of excitement in the clinical community due to recent advances in therapy. What are some of these advances?
Well, there are many new advances in the therapy for chronic kidney disease, but let's not forget what remains most important is reaching appropriate and more intensive goals for the control of blood pressure, glucose, and cholesterol. The latter in particular, because people with chronic kidney disease have a marked increased risk for cardiovascular disease. So that's the basics, and that's the traditional approach. But on top of that, we've known for almost 4 decades that drugs that modify the activity of the renin-angiotensin system, specifically ACE inhibitors or angiotensin receptor blockers, when used in the highest possible tolerated dose, will provide a 20% risk reduction benefit for the progression of both heart disease and kidney disease. In addition to that, just in the past few years, there is growing evidence from a number of clinical trials demonstrating the fact that SGLT2 inhibitors, as well as non-steroidal mineralocorticoid receptor antagonists, may provide incremental benefits on top of ACE inhibitors or angiotensin receptor blockers to slow the progression of kidney disease. But we must remember that these newer studies have utilized these newer drugs on top of highest tolerated doses of either ACEs or ARBs. So it's an exciting time that we now have newer opportunities which are incremental with established ways of slowing the progression of chronic kidney disease.
Wow, okay. Thank you so much for sharing that. As a follow-up to the prior question, many of these agents, such as SGLT2 inhibitors, now have important cardiovascular and renal indications. And in addition, there
original indications for type 2 diabetes. However, outside of diabetes specialists and cardiologists remain reluctant to utilize them, and sometimes they are still viewed as glucose drugs. What is your experience with using these agents in practice, and what is your viewpoint?
Well, the issue with the SGLT2 inhibitors is difficult for clinicians in a sense that we're circling back because the drugs were introduced, 6-7 years ago for the treatment of diabetes, type 2 diabetes, and in large part because they facilitated the elimination of glucose in the urine. Now, fortuitously and serendipitously, we have identified that in all the original safety studies that were done to make sure they didn't cause increased risk for cardiac events, that they in fact have cardiorenal benefits, specifically in slowing the progression of kidney disease, whether you have diabetes or not, and heart failure, whether you have diabetes or not. And this is very exciting. So I think it requires a reorientation of healthcare provider understanding about these drugs, and that in fact, they are cardiorenal protective therapies, really regardless of kidney function, really even down to a GFR of 20-25, and that they should be considered cardiorenal protective drugs, which have the side effect of glucose lowering if you have a GFR above 60. And so this is a real thought process reorientation that healthcare providers need to consider carefully.
Okay, and what is a GFR for those who might not know?
Well, all healthcare providers do know that GFR stands for glomerular filtration rate, also known in the reports that people receive as estimated GFR.
Thank you for saying that. And what are some signs that maybe if someone is experiencing, they should look into visiting a doctor for this type of thing to look out for?
Well, I think many patients are aware of the SGLT2 inhibitors just because there has been a prolific number of advertisements, which are direct to the consumers. And we've seen that, for years now on the television, especially with their newer indications for cardiorenal protection. But I think most importantly, matter of meeting with your healthcare provider to go over the benefits and risks of these therapies and to choose wisely as you incorporate them into the therapeutic regimen.
Thank you so much for your time and expertise today, Dr. Weir. And thanks to all of you for listening. If you have any questions or if you have any feedback on topics that you would like us to discuss in future episodes, we would love to hear from you. You can email us at info@cardiometabolichealth.org or through social media via Facebook at Cardiometabolic Health or via Twitter and Instagram at CMHC_CME. Thank you all, and until next time, have a great day.